Common error: mistaking the left ventricular posterior wall as a pericardial effusion. This happens because in some patients, the posterior wall has a myocardium very homogeneous and with marked hypoechogenicity, what may be mistaken as a pericardial effusion. Like what happened with this child who came for a study because an outside performed echo had diagnosed a pericardial effusion. Another example, here with a very similar aspect. Always be careful with any hasty diagnosis. Check mainly the subcostal view at the IVC right atrial entrance as demonstrated before. Common error: mistaking an enlarged left atrial cavity as a pericardial effusion. We may see an enlarged left atrial behind the posterior wall of the left ventricle and mistake as a pericardial effusion. Usually with a very big LA, part of its cavity may be located behind the posterior wall of the left ventricle. In this situation, a short X view may resemble a pericardial effusion. Obviously, other views will not show the pericardial effusion. The problem here is also to hasten the diagnosis of effusion and not change the initial false perception. The diagnosis also is easily made when we demonstrate the continuity of this cavity behind the wall with the left atrial cavity, but simply angling the probe cephalically. As we see here, in a short X view, it is very difficult to define this space here as a left atrial cavity and not a pericardial effusion. But all this is left atrium, a huge left atrium. There is no pericardial effusion. How to prove it? Just angle a bit the transducer toward the left atrium. When we do so, we're going to see, as in this other patient, that the space looking like a pericardial effusion becomes the left atrial cavity. This is only a problem for those who stick to an initial impression and don't change it. Common error: to mistake the epicardial fat pad as a pericardial effusion. This mistake may be very common if gain is set too low. The pericardial cavity containing fat may resemble an effusion. Usually, it's easy to differentiate, since when the gain is higher, we can see several points inside the pericardium, which is characteristic of fat and not liquid. Furthermore, these points move with the heart, what rules out even a pericardial effusion with fragments of some kind inside or hemopericardium, as seen also here. And to complete the differential diagnosis, there is never a fat pad at the entrance of the IVC in the right atrium. Then, if a patient displays a fat pad looking like a pericardial effusion, we are not to find any liquid. Another difficult problem is to differentiate fat pad from a tumor pericardial implant. Look at this case. Might as well be a fat pad, however, there is also pericardial effusion, and the same kind of texture also attached to the parietal pericardium, suggested tumoral implant. Fat pad is always attached to the visceral pericardium. This was metastatic bronchogenic carcinoma. Another possible error: mistaking the left or right atrial appendage in a patient with pericardial effusion as being a neoplastic implant. When there is a large pericardial effusion, the atrial appendage may be well seen and may be mistaken as a mass sticking out in the pericardial cavity, like an implant. a pericardial metastasis. Look at this left atrial appendage. It sure may confuse your diagnosis. Be sure to certify that any probable mass at this region that corresponds to the place of the left atrial appendage normally, but that you do not identify it in patients without pericardial effusion, may be this structure when a pericardial effusion happens. The differential diagnosis is easy to make by demonstrating the continuity of that structure with the cavity of the left atrium. The same thing happened with the right atrial appendage. It may be mistaken easily as a mass when seen in patients with pericardial effusion in front of the aorta. Other common error: to mistake a left pleural effusion as a pericardial effusion. Notice that you have a large space behind the heart, what may be considered an important effusion, but no space in front of the heart. This is enough to consider the possibility of pleural and not pericardial effusion. A pericardial effusion this large would necessarily present a large effusion also at the front of the heart. Here we have a small pericardial effusion and a large pleural effusion. See these examples. Here, a large effusion which is anterior to the descending aorta and to the heart, so it's a pericardial effusion. Note how it does not go beyond the aorta. This other case, we see a small pericardial effusion since it is in front of the aorta, and a large pleural effusion also seen behind the aorta. Relationship is very important for the differential diagnosis. Look here in this short X of the left ventricle. There is fluid behind the heart. Since it's very large and there is no fluid in front of the heart, you're already supposing it's pleural. But how to be sure? Mainly if it's post-op with surgical opening of the pericardial cavity. In this situation, you only see posterior fluid in pericardial effusion due to the fibrosis between the anterior thoracic cage and the heart, with no pericardial space anterior to the heart. In this case, the diagnosis is made by the relation of the effusion to the aorta. In this long X of the same patient, this effusion behind the heart is also behind the descending thoracic aorta. Then it's for sure a pleural effusion. It may be also in front of the aorta, but must be also behind it. Look this case. There is a moderate effusion and no apparent space in front of the heart. But the effusion is clearly pericardial since it's anterior to descending thoracic aorta. Here we have two effusions. One is anterior to the descending aorta, and there is a bit in front of the heart. Then it's pericardial, and another effusion behind the aorta. Then it's a pleural effusion. The pleural pericardial line is between the pericardial and the pleural effusion. The demonstration of the descending aorta is a paramount importance to differentiate a pleural from a pericardial effusion. Large space behind the heart, but not behind the aorta, is pericardial, and behind the heart, but also behind the aorta, is pleural. Don't ever forget to look for this relationship. A right pleural effusion will be detected when during a long X of the epigastrium we see the liver, the diaphragm and the effusion cephalic to it. But a better way to demonstrate the presence of a right or left pleural effusion is to sit up the patient and scan his left and right back from the abdomen to the lungs.